My name is Dr. Sue Whitney. I'm a professor at the University of Pittsburgh, and I have the honor today to talk to you about BPPV, the importance of torsion, and performing the maneuvers accurately. So the outline here, what we're going to try and do is I'm going to try to describe the importance of performing the canalith repositioning maneuver, especially relating to the changes in gait and falls that are and false incidents that has clearly become very important in the literature over the last 2 to 3 years, especially, and also to describe the use of accelerometers, artificial intelligence, which is everybody is talking about, and the new technology that's being used to assist in the diagnosis and treatment of persons living with BPPV. So if you take a look, this is what we all do. We take people back into the Dix-Hall pipe position. This is the left. And obviously, I don't have my head up, but I'd be down looking at the person's eyes and trying to figure out what's going on. And some of the technology that's being developed today actually hopefully improves our ability to make the diagnosis and probably in the future be able to predict whether the person is going to get better after the maneuver that you just performed, which is pretty exciting. So what's going on here? This is a recent systematic review of dizziness in older people. And in this review, there were 2,148 older persons between the ages of 60 and 90 in these studies that presented with vertigo. So there's a lot of studies out there on persons living with vertigo. And vertigo was reported number one in audio vestibular disorders. That's the number one reason why people report vertigo. It's not cardiovascular, that's behind at 20.4%, nor is it because of neurologic disorders. So the number one reason that people complain of dizziness is because of vestibular disorders. And that's why you're here today, because you see people who are dizzy just like I do. The audio vestibular disorders are the most common cause, and that's a take-home message for all of you today. Now, the leading authority, at least I would say in the world right now, is the Clinical Practice Guideline that was published in 2017. It's old now. I know it sounds ridiculous, but it is old. And it's old because there's so much data being produced now about BPPV. There's data from all over the world. And this CPG needs to be updated. There's 99% of the information is dead spot on, but there's a whole lot of new data that really could, I think, improve the care of people living with BPPV. So let's take a look. In BPPV, the statement from the American Academy of Head and Neck Surgery here in 2017, what did they say? They said there's high-quality evidence that patients diagnosed with benign paroxysmal positional vertigo should be offered expeditious treatment with the canalith repositioning maneuver. That doesn't mean go home for 4 weeks and come back if it's not better. That means they should be treated. It says that in the guideline, it says BPV should be diagnosed with the Dix-Hall pike and roll test, which you all know how to do. The type of Nystagmus should be noted and drive treatment. And we need to perform or refer to a clinician who can perform a canalith repositioning maneuver. Now, in terms of the type of nystagmus should be noted and drive treatment, that is sometimes easier said than done, which is a figure of speech, meaning it's not all that easy. It's a challenge sometimes to figure out whether there's torsion. Is that straight downbeating? Do I see downbeat torsion? So there's an art to this too that makes it much more difficult, and that's why things like looking at eye movements with video oculography makes this so, or with the video goggles here, makes it so much easier to figure out what you're actually treating and whether in fact the treatment was effective. So let's look at some of the information recently from Kim et al. In 2020 and 2023. They talk about self-treatment of recurrent BPPV, and it's a randomized trial. So people previously diagnosed with BPPV, there were 585 of them, were randomized. They received a questionnaire to make their diagnosis. So they'd already had BPPV. Then what they did was they They called and said, I've got BPPV again. They gave them a questionnaire to help make the diagnosis. And then they gave them a video clip about how to treat for the people that were in the experimental group, versus the other group was sent a video of how to treat the side and canal from the previous visit. So Kim and colleagues have found in the past that that if you try and treat the same side every time with BPPV, the chance of you actually being on the right side and in the right canal is only it's under 30%. So it's not always in the same side, same canal, every time the person has BPPV. That's take-home message number one. So 21% of these people had recurrence within 2 years or longer. So 21% of these 585 people said, I have BPPV again, all right? And 85% who agreed to participate used this web-based system, and 72% in the treatment group, and 43% in the control group reported no vertigo after the web-based intervention. What that's saying is that if you treat the same side, that's not going to be nearly as effective if you use Kim's questionnaire-based information and use the video clip. So 72% of them got better when they answer the questions, and the AI, the artificial intelligence system, was able to best make the diagnosis much better than just, this is your right posterior canal, here's the video for the right posterior canal, do it again. So that probably isn't best care. What they stated was that the artificial intelligence program used for this web-based system is not foolproof. It wasn't 100%, right? Their 6-question questionnaire had a sensitivity and specificity of 87% and 89% for diagnosing BPPV. And that was in the first paper that they put out in 2020. So it was 6 questions, and it fairly well identifies that they have BPPV and which side it is. The AI program incorrectly diagnosed the wrong side or the wrong type of BPPV in 28% of the cases. So it's clearly not foolproof. I'd like to think that we as clinicians are better than the AI, but I'm not sure about that either. What I found was interesting in the paper was that 143 of these people declined to participate, which is about 20% in the study, because they couldn't use the internet. They had some spinal problems and didn't want to hurt themselves, most likely. They just said spinal problems, and had multiple canal involvement or had cognitive dysfunction. Take-home message from this is that AI might be helpful, and maybe this could work with people if you sent them the video. A lot of people, it did work, but at 20% of the entire sample, that 500, they weren't willing to participate because, and what they didn't ask too is that I would bet some of them were fearful of falling or afraid to do it themselves. And that's another reason why they may not have agreed to participate. So telehealth, AI, it may not work for everybody, but it looks like it's very promising in this area, but not for everyone. Now, this is the original Kim paper from 2017 that I just cited. And the pattern of recurrence varies in people with BPPV. And they said that the instruction for self-administration of a specific CRM based on the previous type of BPPV may have limited efficacy in this frequently recurrent disorder. It's a direct quote from the paper. 24% of them showed a recurrence in the same canal on the same side. I said up to 30, it's 24, right? So 24%. That's still, 1 out of 4, that it's not going to be on the same side. So that's a real problem if you just tell people to do the CRM based on what you saw in the clinic that particular day. And here's the data from the paper, the pattern of recurrence. Only 24%, like I said, were the same. So the type, how this works is that this is identical. So 40% had the identical type of BPPV, meaning the canal. 58% had the same side, but for the same side and the same type of BPPV, it's only 24%. So this is not great. There's a lot of folks that are going to be here that it's different, and that's why the repositioning maneuvers, if you just call and tell them try and do this based on what you just had, it probably won't be effective, or it may not be effective. It will be in some people, obviously. Now, I wanted to let you know about the number of papers related to BPPV over time. And if you look here, this paper came out in 2023 in Frontiers. It starts here in 1974, and there were for the first couple years, there was only one publication on BPPV. Now look at 2021 was a very good year for BPPV. The biggest, 125 people. And that probably dropped off because of the pandemic, because people couldn't collect a whole lot of data. But 125 papers about BPPV. There's a huge number of publications about BPPV, and it's really interesting where they come from. If you look in 2023 in this paper, most are actually coming from the United States. But even from the United States, the authors are working with people from other countries, which is what the red looks like here. China, you can see, is next. So China has produced the most papers about BPPV after the US, Italy, and Korea. And think about the size difference in these countries. It's pretty remarkable. There's some amazing folks who are writing lots of publications about BPPV over the years. Right? So more and more data every day. I feel like I read another BPPV paper. Now, if you take a look at kind of where these papers are coming from, look at the big green here in Seoul. So I always say South Korea, Japan is big. If you look, here's Hopkins, and I work here at the University of Pittsburgh here, but you can see that around the globe, it's certainly not just one institution, one person. But there's a huge group of people from all over the world who are contributing to BPPV, and that's our knowledge. Now, this is the paper from Walter that I like that's so wonderful because it shows the human otoconia here in the upper left, and this is the kind of the matrix that it sits within, and you can see how young and nice this little otoconia is in a young human. So these were the first pictures that I saw of human otoconia that were this clear. Now look at Walter's paper, Older Adults Otoconia. Can you see here how different they look? Look at the fissures. They're still the same shape, but they don't look anything like the previous picture that I showed you for otoconia. So there's a clear difference in older adults otoconia versus young. So we know that older adults otoconia really do look different, and that may be one of the reasons why people develop BPPV. Now, what's the sensitivity, kind of accuracy of diagnosis and manual repositioning in BPPV? Kind of what are the facts out there in the literature? So that's what I'm going to share with you. This is a paper about two-dimensional VNG. Can it identify the side of the lesion in posterior canal BPPV? And the answer is it's not great. So the Dix-Hallpike test is part of the VNG. It's done frequently, but it doesn't pick up that torsion. That's the problem. And in this study, they attempted to determine the prevalence of what they call discordant, equivocal, and concordant nystagmus tracing in posterior canal BPPV versus an eye video. So what doesn't agree, yes, no, and then definitely agrees with is what those words mean. So posterior canal BPPV, there were 94 people. Here, 4 were bilateral, and they had 100 videos with the VNG tracings, and they were reviewed to determine what the nystagmus patterns were. 62% had a right posterior canal, and 38% had a left posterior canal, and that's consistent with the literature. The literature always suggests that it's more commonly on the right side than the left, and another study almost reports the same numbers, about 60% on the right, 40% on the left. So this is very consistent with what the literature says. 65% of the time, VNGs did not identify BPPV, and the VNG was ambiguous 29% of the time, means you couldn't tell, and 6% of the time it agreed with the clinician. All the tracing errors involved the horizontal channel. So their conclusion was that this two-dimensional VNG tracing is not reliable for identifying the nystagmus trajectory in posterior canal BPPV. So this three-dimensional, we're missing the torsion. And when you miss the torsion, it's really, really hard to figure out what's going on. Now, how accurate are we with our repositioning maneuvers? That's another thing that's really important, right? And this particular study, they recorded the angular accuracy of a clinician-guided Epley maneuver with a 3D axis accelerometers. They put this accelerometer on the head, and they try to figure out how accurate are you when you do a repositioning maneuver. They just took 10 healthy people and 5 right-dominant clinicians who performed the Epley, and they did this 20 times. So they did 20 Epley maneuvers, all right? And they recorded the angular movements using an accelerometer, and angular errors were noted throughout. So they tried to figure out, based on what John Epley said, where the head should be and how far off they were. The head turned to the left at 45 degrees for the left ear maneuver had an average error of 2.9 degrees, all right? Now, this is where it got a little bit more interesting. The patient faced the floor when their head is down at 135 degrees from supine for a right ear maneuver had a mean error of 17.6 degrees. If it's all about angles, if you think about this with your ear here, if it's all about angles, 17 degrees may make a big difference with whether, in fact, this is going to be successful or not. So there was a wide variability in angles, even with experienced ENT professionals doing the Epley. We don't know yet how far off the correct angle can be and still produce an effective repositioning maneuver. So maybe it's 1 or 2 degrees that's critical. Maybe it's 10 or 15. We don't really know what the margin of error is that you can still be effective, but it's really interesting and exciting, some of the things that they're doing here to look at how good we have to be to make this work. So we don't know what's the best angle for the canal's repositioning maneuver. Patients may have difficulty performing the canal's repositioning maneuver themselves precisely according to the American Academy of Head and Neck Surgery's guidelines. So how do they know whether they're just 17? If the professionals are 17 degrees off, I have no idea what the patients doing the self-Epley are. So that's something to think about. The barbecue roll maneuver here resulted in substantial rotational errors, especially in older adults. And errors by the specialists ranged anywhere from 10 to 20 degrees off, according to Kwan's paper, et al., And they suggested that real-time data about head angle might improve treatment success. So if they could figure out where they were in space, maybe that would make a difference in the outcome. So part of what that Kwan has done is he's been looking at, and his colleagues, they've been looking at how thick the surfaces that the person goes over. So for example, this is a right right Epley maneuver, right? Now, if you do it this way, we know that this is as good as the standard Epley and a paper that came out in the Journal of Vestibular Research. You can see that the head angle here is anywhere between 18 and 26. With the thicker foam, it's 26 to 34 degrees. And here we're at 36 to 44. And this is, in my mind, that looks like a lot of extension. So these 3 pillows under the shoulder here actually put them in different degrees of extension. And I always say it's not just doing the maneuver, but it's how much extension you get. So I always tell people you've got to be careful not to use a pillow that's way too high, or you're going to get too much extension and you may end up with some problems. Okay. The IMU guided system for BPPV, this is another cool study where they actually used an IMU to figure out where the head was in space, and they educated people with BPPV. They had them do the self-treatment. Then they re-educated them about the errors following the CRM using the IMU. So they said, no, you need to go this way or that way, change this angle. And they did the same sequence for the barbecue maneuver, but always treated the right side. The IMU talked to the patient. So it's saying up a little bit, Sue, to the right a little, to the left, etc., and provided feedback to get them at the correct angle. So they actually tried to get them in the right space, and they retested them 1 hour later with the Dixhall pipe. And errors were smaller in the IMU self-guided repositioning maneuvers, which makes sense because they kind of learned where the position was. And the treatment success was 71% for the Epley and 100% for the barbecue. So this paper in 2023 really suggests by these colleagues that this self-guided maneuver may be effective. So who knows, we might be doing this in the future too. Now, this is a comparison of self-treated versus specialist-treated and comparison of a group of educated and those who had an IMU to guide them with the maneuvers. And they're two different studies. So, but they look, you can compare the data. So here's the angle in degrees, and here's the number of Epleys on the horizontal axis. And you can see here, this is the self-treated group versus the specialist-treated group in terms of the angles. And the specialist group is clearly tighter than the self-treated group, right? So you can see that there's a big difference between, well, I don't know how meaningful it is, but certainly the group that is specialist treated, thank goodness, it looks better than those who are self-treated. And over here, this is the Epley group versus the IMU group. So the IMU group is in the green, and the educated group, you're taught how to do it, is here. So when people are self-educated to do this versus having the IMU, you can see that there's clearly a decrease in the variability. So maybe we'll all be using IMUs in the future too on our patients if we ask them to do this at home. My issue is you may never get the IMU back, because that's a problem I always have in my clinic. Why is the diagnostic accuracy important in BPPV? Older adults with BPPV can fall as a result of their BPPV. They can get BPPV and fall, or they can fall and get BPPV, either one. Falls in older persons can cause increased morbidity and potential mortality. So people can actually die, even though it's considered a benign condition. If you fall and hit your head, you can actually die from BPPV. So we want to prevent this. And people don't live well when they have BPPV. So if you look here at social isolation and falls, if falls is in the middle, it can result in social isolation, sedentary behavior, reduced physical function, and fear of falling. And gait and falling in BPPV, this is a recent meta-analysis of fall studies in BPPV, and they found that BPPV increases the odds of falling and negatively affects spatial temporal parameters of gait. The canalith repositioning maneuver can decrease falls, decrease fear of falling, and improve level walking. And this is a different systematic review and meta-analysis of 10 trials in people with vestibular disorders, and they found they had poorer walking ability than control subjects, and 22% of them with BPPV had reported a fall. And the overall prevalence of falls in people with vestibular disorders was 60%, but it's pretty significant. Most of these studies only had one vestibular test that helped make the diagnosis. So some of you might not believe they had a vestibular disorder, but they did include them in the analysis. So they encouraged the use of the head impulse test, the Hallpike-Dix, and also the oculomotor exam to determine fall risk. And they think a fall risk assessment should be included in part of the examination of persons with vestibular disorders. So there's a World Falls Guideline for prevention of falls, and they state that you should screen with history taking and on indication perform the Dix-Hallpike and the head impulse test. And I don't agree with this at all, neither to several of my colleagues in the UK, that you have to do more than that. You can't wait. So what's the data here? BPPV and falls, all right? 40 people over the age of 65 were referred here to a UK clinic for falls, and they were asked how many times they had fallen. They followed them for 6 months, but this is the key. The last bullet here is the key. 12 of the 40 people with nystagmus and Dix-Hallpike did not report vertigo during the nystagmus. Wow. That's really significant. So 12 of the 40 didn't report vertigo. So if you go back and we take a look at this again, at the World Guidelines, they say screen on indication and perform the Dix-Hallpike and the head impulse test. Then we've got a problem here because they're not saying that they're dizzy. So there's no indication to actually do a Dix-Hallpike. So think about this, and let me take it a step further. There's a concept out in the literature now called vestibular agnosia, and it came out of the UK, out of UCL London. And Zolari and Handy reported that persons with vestibular agnosia cannot interpret vestibular sensations. And what they're calling vestibular agnosia is an inability to actually say that they spin. There's damage to the area, probably of the right temporal lobe, is what their studies seem to suggest, in older people and persons after brain injury. And as a result, they're not able to say that they spin, so that the spin area seems to be turned off in these people, and they don't say that they spin. Now, we've done some work, Dr. Harrell and I, related to BPPV and brain injury here at Pitt, and this was a setting in inpatient rehab. And 76 people were tested with the Dix-Hallpike, and 42 of the 76 had a positive Dix-Hallpike when tested. This was anywhere from a few days to a few weeks or more after they had had major brain injury. Only 4% of the people were able to report symptoms of dizziness when they had the Dix-Hallpike done or the roll test. So only 4% could say they were dizzy. And so the conclusion of Dr. Carroll's paper is that positional testing should be required for all people with moderate to severe brain injuries in rehabilitation settings. Now, we've also gone on, I participate in this is in press, we looked at BPPV in the side of the brain injury, and there was absolutely no relationship between MRI or CT scan side of lesion and the side of BPPV in persons admitted to the rehab unit. So there was nothing there. So you have to check both sides. Don't think if the brain injury is on the right side, that's the side of their BPPV. Not true. It could be either side. So just be aware. No difference. Now, this talks about gait and some of the things related to falls and the minimal clinically important difference in gait speed in people with unilateral loss. And I just wanted to put this in because it's so critical that now we have an idea of what minimal difference is in terms of change of gait speed. So a change of 0.2 to 0.34 meters per second was required to see a large difference in perceived balance confidence and dizziness handicap in persons primarily post-surgery after about 6 weeks of rehab. And most of them had had a schwannoma surgery. So you have to see a pretty darn big change in gait speed in persons after unilateral, surgery, right? And there's a paper by Rachel Whalens, I think, that says maybe closer to 0.2 that came out last year in 2022. But I'm a little bit more conservative here. And this is at least what they stated was a minimally clinically important difference in persons after schwannoma surgery. Okay. Now, why might people have recurrent BPPV? And this is totally theory. In my mind, because there's only one paper like this, but I thought it was fascinating. So this is a prospective study where they attempted to determine whether cerebral inflow and outflow abnormalities assessed by ultrasonic examination was associated with recurrent BPPV. So flow, right? So flow in and out of the brain, does that make a difference? So they studied 24 persons who had experienced at least 2 episodes of BPPV. And during the ultrasonic exam, ultrasonographic exam, 22 of 24 patients, or 92%, had one or more alterations of the extracranial venous circulation. So this is they call chronic cerebrospinal venous insufficiency. There's not enough blood flow, venous circulation. There's alterations in venous circulation. They said there were also alterations in the extracranial venous circulation in the person studied. And maybe this lack of normal venous flow via either stenosis, blockage, regurgitation, or abnormal valves might disturb the venous ear drainage, affecting blood flow, which may cause recurrent otolithic detachment. I don't know, but I thought it was fascinating. It's the first time I've actually come up with or seen a theory that somebody actually suggests why people might have recurrent BPPV. Could be dead wrong, but I wanted to put it out there to you because I found the paper very interesting. Now, the use of a questionnaire to make the diagnosis, this goes back to the what I had talked about previously. This is an AI, artificial intelligence concept. 6 questions were utilized, 3 to diagnose the BPPV and 3 to determine the side and type of BPPV. Right? So they had 578 persons who participated with dizziness. They completed the questionnaire before positional tests. And of the 200 patients with a questionnaire-based diagnosis of BPPV, 160 or 80% were confirmed to have BPPV. So questionnaire clearly identified that they had BPPV. So that's a great screening tool to determine if the person has BPPV. Of the 378 patients with a questionnaire-based diagnosis of non-BPPV, 6.3% were found to have BPPV. So they didn't miss too many. That's really pretty good odds. So they said that the sensitivity, specificity, and precision of the questions was 87%, 89%, and 80%. Not bad for 6 questions. Quick and dirty, can help you make the diagnosis of BPPV. So I'd suggest you consider pulling that paper. The artificial intelligence and BPPV. So during testing for BPPV, up to 10 minutes of data are produced, making the AI-informed real-time diagnosis challenging. It's like, it takes too long. So that's right now, the AI in this particular study took way too long to figure it out. So Wu et al. Proposed a combined kind of 1D and deep learning composite model where they used head traces and eye traces to figure this out. But the take-home message is that it's taking too long, but artificial intelligence may help us make the diagnosis of BPPV very soon in the future, and that these models can accurately detect and categorize the subtype of BPPV. So the questionnaire is one way that the world is going, and then the other way the world is going is artificial intelligence. May end up being a combination of both in the next 5 to 10 years for BPPV management. Now, does it matter who does the testing? And the answer to that question is maybe. All right. So medical students versus those trained in neurology, can they choose the correct side for geo and apogeotropic horizontal canal BPPV? They looked at 44 video clips of nystagmus during the supine head roll test for patients with geotropic and apogeotropic horizontal canal BPPV, geo beating towards earth, apo beating away. They quantified the intensity of the nystagmus using goggles, and they showed the videos to 14 medical students and 11 medical trained personnel in neurology and neurotology, and they reported the side of the lesion. The bedside lateralization of horizontal canal BPPV was 83% after the first presentation and 86% after the second. The accuracy was more closely correlated with the asymmetry than the absolute difference. So for geo, if it wasn't really clear, like boom, 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 that's pretty clear that this is the involved ear. So when it was harder to pick up, everybody had more difficulty. They said the accuracy of bedside localization of the affected ear was acceptable if the nystagmus asymmetry was more than 30%. Otherwise, it was much more difficult for them to figure out which ear was the involved ear. And they did find that the neurologists did better than the medical students. Now, in the nystagmus pattern recognition by Kong in 2023, they worked on eliminating invalid frames from blinks and eye closure and they talked about using the deep learning to develop their program and analyze the nystagmus. Their model achieved a precision rating of 95% with classifying nystagmus patterns, and 98% of the time they were able to recognize the torsional nystagmus direction. It's pretty darn good. iPad diagnosis, this didn't work so well. They're trying to use it to make the diagnosis of any kind of vestibular disorder, but they did have 94 people with BPPV included in their cohort out of, this is out of Munich, I think, or certainly Germany. Sensitivity, specificity, and positive negative prediction values for BPPV were 61%, 98%, 86%, and 93%. But they said the sensitivity was low, and when they used this iPad to try and make a diagnosis, especially for vestibular migraine. But people were using all kinds of technology to make the diagnosis, and that you should definitely be aware of. Now, if you use a visual aid, this thing over here, this lovely ear, if you use that for repositioning, does it improve the accuracy of your head positions? So they took 10 healthy young controls who experienced 3 Epley maneuvers with and without guidance, 3 with and 3 without this head gizmo, head device. They were performed by one clinician, the maneuvers, and they used a motion capture system to record the movements. And the movements were based on a model developed from a micro CT of the temporal bone. Rotation error was significantly reduced, especially for the nose down to the ground with the device. Mean error of 20 degrees versus without the device, near 40 degrees. Remember earlier I said that it's the nose down that had the greatest variability. And their visual guidance device increased the accuracy of the canal repositioning procedure, but we don't know if it improves the treatment efficacy. So they haven't tested it in patients, but they did publish this very interesting paper in normal controls. So there's other kinds of guidance systems. Bondari has a guidance system that decreases the variability of the maneuver by 6-fold. So she's using a guidance system out of India. And so there's people are using all kinds of devices around the world. And she's developed some incredible videos that you can take a look at. If you can pull the papers in the back, there's usually a URL that you can click to actually see these movies. And her system, this is what her system looks like here on top of the head, and with and without guidance. So with guidance, you can see that the variability of the head angle is much less. This is head right, if this is the right sulpike, head left, nose down, and then back up to the sitting position for step 4 of the Epley. And you can see it's much tighter with the red versus without the guidance. And it was statistically significant, statistically significantly different with and without this on top. And there were 25 experienced clinicians who tested 25 young volunteers twice, and those are how they achieved those data. So can AI assist with the clinical diagnosis of BPV versus vestibular paroxysmia, Meniere's disease, and vestibular migraine? And again, the script used a multivariate analysis of machine learning with DizzyReg, which is a large registry that they've got in Europe. They compare BPPV, vestibular paroxysmia, Meniere's disease, and vestibular migraine, and the diagnostic accuracy ranged between 26 to 50%. So here we're still saying we need some humans to make the diagnosis and assist. It's really hard, especially between Meniere's disease and migraine, to come up with that diagnosis. So I wanted to show you some data. This is a flat, and you heard this from Michelle earlier, Dr. Petrick. Flat, consistent torsion. This is about 2 degrees per second. You can see that fast rate beat there, just 2 degrees, just to show you here. Now here I want to show you, this is a flat, consistent torsion, about 2 degrees per second. So we're going to try and show you the whole shebang. And back, eyes open. Need you to do it, okay? So you can see this is really guided, that you can figure out where your head is in space, figure out if you're at the right angle. You can get the torsions, slow phase velocity down here. Now I'm going to show you the next one. And you can see, look at the difference here. This is a positive dipsulfide here. And look at the left side here. This is a more traditional pattern, the slow phase velocity here. And then it does settle down to 0, and then you're going to see it reverse over here. So that's what I want you to look at.
So deep. Or down, dizzy. Gone. Don't is it a group 5 seconds? Oh yeah, he said it. That would be right back. Now that one was probably a 5. Half it. Yeah. It wasn't as bad. Once again, I'm going to say that the first time I did this, I'm going to call that my 10. Okay. I've had him hand study. Yeah, it was about half as bad. Probably only because of the duration. The first initial hit was pretty good, but then it went out real fast. Yes.
I'm going to stop it there. What I want you to if you listen to it carefully, what you heard was, whoa, I'm dizzy. And then right at the time when we stopped seeing this increase in the slow phase velocity, that's when she actually said she was asymptomatic. When she's brought back up, you actually see the torsional downbeat in the opposite direction. So it's really fascinating that you can capture this basically in time on film right in front of you. So how to analyze the torsional eye movements? So we analyze the slow phases here, and the slow phases are kind of to the right. The peak here is at 40 degrees per second, and it gives you an idea of the intensity. And she said, whoa, this is bad. Now let's take a look here at a 51-year-old woman who reports dizziness with a change of head position that's gotten worse in recent weeks. Tying her shoes and looking back over her right shoulder increase her symptoms. And she reports dizziness from getting out of bed, rolling, and with quick head movements. Based on reporting sometimes of getting out of bed and rolling, she has an estimated probability of having 33% of having BPPV, 33% based on the response to those two questions. Her DHI was 36, her Dizziness Handicap Inventory. Her ABC, Activity-Specific Balance Score, was 85, and she rates her dizziness vertigo on a 0 to 10 scale prior to treatment, ranging between 0 and 7. All right? So we're going to take a look at her here, and she's going to say something interesting that I want you to listen to.
Hello. So I'm like that. Oh. You're going to better. Cute. I didn't just spin. Oh god, it's a horrible. Oh, this one's probably like tilting. So in the cabin. Oh, so like 7 out of 10. Substance freaked out.
Now, this is the same woman the next time she comes in, second visit. Take a look. There's no nystagmus, none whatsoever. It's totally clean. No torsional sulfate velocity. Everything is to. So that's what it's supposed to look like when the person does not get BPPV. All right. So what's the take-home message here? With this patient, she said, "Did my eyes do anything? I didn't actually spin." That's what she actually says. So she didn't actually say she spun, but we saw the torsional eye movements that were pretty extreme there, right? She said she didn't feel well. She had some nausea, but no vertigo. So don't rely on the word spinning or vertigo when you're working with your patients. We recorded 13 seconds of torsional being nystagmus to the right in the first video. Without that torsional indicator, it would have been much more difficult to see the torsion. Plus, she didn't feel the vertigo, making the diagnosis more challenging. So this technology and technology like this is going to improve diagnosis. So just to sum up here, this is a really nice site where you can learn more about eye movements. The Dan Gold Neuro-Ophthalmology collection on Noval, which is at the University of Utah. If you use this URL, you can actually get to the site and you can learn a lot more about eye movements. So key unknowns at this point, we don't have all the answers. How critical is the head positioning angle when doing the CRM? Which patients should be taught to self-reposition and which should not? What are the problems associated with self-repositioning, the risks and the gains? And is the use of AI beneficial in making the diagnosis of BPPV without a skilled clinician involved? And how will we best use technology in the future to manage BPPV? These are all things we have to be concerned about. So in conclusion, artificial intelligence is not sophisticated enough yet to assist with the differential diagnosis of BPPV versus other vestibular disorders. IMUs and eye recognition software have great promise in improving care of persons living with BPPV. And knowing where the head is in space throughout the maneuver may help treatment results, plus might decrease the chance of creating both canal jam and multiple canal involvement. Thank you very much for giving me this opportunity to speak to you today, and I've provided you with some references for the talk.